Great. It's now 12:30, and so I would like to thank Professor Thomas Koch for taking time to speak to us about childhood headaches. I know that this is a situation that kind of stumps most people. They're not sure how to handle that, how seriously to take it, what the next steps should be. And so Professor Koch is not new to us. He's a friend to the Department of Pediatrics at Aga Khan University. He's a professor of pediatric neurology at the Medical University of South Carolina, who visits Kenya as often as he can. He has presented previously on headache at the Kenya Pediatrics Association meeting about 2 years ago, and he's given similar talks to the department and is currently engaged in teaching and research as appropriate within the department. So welcome, Professor Koch, and yes, take it away. Thank you.
Great. Thank you so much. I appreciate that. And I appreciate the opportunity to present this topic as Professor Samia knows. This is a topic which I'm very interested in. It's one of my focuses clinically back in the US. And I do a lot of speaking to our students, residents, and local physicians on this topic because this is a very common problem. Okay. One of the questions is, well, why talk about headache? Headache occurs in at least a minimum of 10% of the pediatric population. And there was a paper within the last 2 years showing that in Western Africa, the incidence of childhood headaches was over 50%. And a lot of this is just unclaimed. I mean, children come to us and say, oh, my head hurts, and say, okay, go lie down, have a glass of water, maybe take ibuprofen or acetaminophen or something along those lines. And it doesn't really register at how bad this problem can be and what it may evolve into, which starts out, once in a while when the child is 6 and 7, may be very different when the child is 17 or 27 or 37. And what's important in the evaluation of anyone with a headache, but definitely children, is a proper history and physical examination. That's really what I'm going to spend a significant amount of time on, because by doing so, it really negates the need to do costly studies such as neuroimaging. Unfortunately, in the US, we have a problem that many children who don't have good continuity of care will go into our emergency department with an acute issue. And the first thing that the emergency department does is they obtain some sort of imaging study, whether it be CT or MRI, without really first investigating the history and physical and seeing if those tests are warranted or not. Migraine is the primary cause of recurrent headaches at all ages. Whether you're 6 years old or 60 years old, it is the major cause. And it's the recognition and familiarity of migraine in the pediatric population, which is crucial for the proper treatment of recurrent headaches. And it's important to know, well, I know what a migraine headache looks like in an adult, or as an adult, I have migraine headaches, but we have to recognize that in children, things oftentimes manifest in a slightly different manner. And so it's important to bear that in mind. What are the features that are characteristic for childhood headache and not just headache? So where do we begin? The child comes to the office, comes to the emergency department, comes to the clinic, and one of the issues that the parent brings up or the child brings up is, gee, I get headaches. Okay, now what do we do? Well, in thinking about headaches, let's first look at, well, what are the two possibilities? And the two possibilities is this could be what we call a primary headache, or this could be secondary. And secondary is secondary to things that we don't like, such as brain tumors, as seen in that scan, MR scan. But it could be due to hypertension. Okay, it could be due to infection. Okay, it could be due to increased intracranial pressure, such as idiopathic increased intracranial pressure. or it could be what we call a primary headache, and the most characteristic primary headache is migraine. And then migraine is a spectrum, as we'll talk about a little bit later, but it includes all kinds of things from the classic sort of migraine with aura to just recurrent headaches or headaches which have some tension-like features. The difference between tension and true migraine is really kind of blending together because the pathophysiology for recognition of pain in the head is really the same pathophysiologic pathway, which is the trigeminal system, as we'll talk about in a moment. So this is our differential. The child comes to us. Does the child have a primary headache or does the child have a secondary headache? So how do we discern that? Well, what we do is we take a history, very basic, an important history, but a history which is targeted towards headache and headache differentials. We then do a physical examination, and depending upon the results of the history and the physical examination, if we are suspicious that this may be a secondary headache, then some sort of neuroimaging is warranted. But if it's not, all the evidence shows us that there's really no need to do neuroimaging if our history and physical really suggest more of a primary headache disorder. So then the questions are, well, what are those historical features? What are those questions that we need to ask the child or the parent that will help us discern from the history that we're either primary or secondary? Well, one of the first things that we always ask, child comes in, says, gee, I have headaches. Well, how long have you had headaches, right? That's always the first question. So how long has this been going on? Has this been going on for the last month, or has this been going on for the last 2 years? Okay, very, very important to discern between an acute issue and a chronic issue. And so one of the magic timelines is about 6 months. So if a headache has been going on for 6 months, always been getting headaches on and off for, the last 8 months, well, then we tend to think of that as more chronic, recurrent headaches versus something acute. This just developed 2 months ago. Okay, that's a slightly different historical feature. So that becomes important. Is this acute or is this chronic? Then the next question we ask when they say, well, headaches have been going on now for 6 months. Well, how often are you getting headaches? Are they occurring once a month? Are they occurring once a week? Are they occurring every other day? And how long are they lasting? Okay. And that then helps us discern what really is what we'll call, as you'll see in a moment, the headache burden. How bad are these things? How much are they impacting the child's life, but not just the child's life, because the child's life will affect the parent's life. And so there's a very big ripple effect. Like if you or I have a headache, okay, we have our downtime and we may not get the work done that we need today. But if a child has a bad headache and is vomiting or can't get up or crying in pain, well, all of a sudden, mom's work is disrupted, maybe even dad's work. It's a total disruption to the family. And so it's important to kind of recognize what we call the burden. The next question is this a pattern of, is this acute? Boom, this just happened today and I have a really bad headache. Okay, that puts it in a slightly different category. No, these are headaches that come and go. In between these headaches, I'm completely fine. But when I have the headache, I'm really out of commission. Okay, so that's a very characteristic pattern that we most recognize with migraine. Or no, these headaches are getting worse. They started out 3 months ago, once a week, then it started increasing. And now they're every single day. That progressive pattern is another important feature. Or no, I've been having headaches for a long time. I remember a rather entertaining story when I was a medical resident many, many years ago. One of the first patients, this is when I was doing adult neurology, one of the first patients that I saw was a woman in her 60s, and she came in complaining of headaches. And I said, Ma'am, how long have you been having headaches? And she said, 40 years. Okay, so all of a sudden that puts it in a very different category. The headache's been going on for 40 years versus it's been going on for 4 weeks or 4 days. Where do the headaches occur? We usually ask. Well, where on the children, I say, where on your head do you feel the headaches? Do you feel it in the front? Do you feel it on the sides? Do you feel it in the back? And for children, most of the time they'll imitate it, but the vast majority of the time it's frontal. We recognize historically that migraine tends to be temporal, right, on the side of the head. In children, that's not the case. In children, it's generally frontal, retroorbital. It may start moving to temporal, especially as a child progresses from childhood to adolescence to young adulthood. But bear in mind that this classic, oh, it's not on the side of the head, doesn't negate the fact that this is probably migraine. A difficult question for many children, including adolescents, to answer is what's the quality of the pain? What's it feel like? And oftentimes, rather than just saying, what's it feel like, and waiting for them to respond to an open question, I'll actually say, what's it feel like? Does it feel like a pounding? And I kind of imitate that on my hand. Does it feel like a pressure? And I'll kind of squeeze my hands together. Does it feel like a stabbing? I give them words so that they can kind of choose a word, because oftentimes it's very difficult for them to say what it really is. And in young children, even with the words, they'll say, I don't know, it just hurts. And then at that point, you say, okay, fine, it hurts. I got it. When do the headaches occur? Do the headaches occur in the morning, the afternoon, in the evening? And do the headaches wake you from sleep? We've heard in the past that headaches that wake you from sleep oftentimes can indicate increased intracranial pressure. This is true to a point. The point is the time when increased intracranial pressure manifests itself most with headaches is actually very early morning. So 4, 5, 6 a.m. in the morning. But the 1, 2 o'clock in the mornings are usually not the increased intracranial pressure headaches. So sometimes the time of day can be helpful. And then, of course, the other thing that's very important are what are the associated features? When you have your headache, do you have nausea? Do you have vomiting? Okay, very characteristic features seen with migraine. And you don't have to have both. You can just feel nauseous. Sometimes you can just vomit without the nausea, but vast majority of the time, nausea is a key feature. Young children will complain about abdominal pain. And on a slightly different topic, there is a form of childhood migraine called abdominal migraine, which really manifests with abdominal pain and not that much head pain. So there's a big overlap between the abdominal system and the brain, as probably you've heard. What happens? Do you ever see anything funny? Do you ever get any wavy lines or get any blank spots in your vision that precedes or occur at the onset of the headache? And looking for a visual aura. Recognizing that migraine can occur with a visual aura, or it can occur without a visual aura. And in fact, the vast majority of the time, it occurs without a visual aura. Visual auras, whether you're talking about childhood migraine or adult migraine, only occurs 20% of the time. So it's actually not as common as the textbooks and what we may have read or heard in the past would indicate. The one thing that we don't want to hear is double vision, diplopia. Do you ever see two? What about if you look to the sides? Diplopia usually is a sign of increased intracranial pressure and not of migraine. So that's a biggie to recognize if that one pops up. Very commonly, anyone, whether it's an adult or a child, will complain of sensitivity to light and sound during the headache. And again, that just reinforces the fact that this is probably indeed a migraine. Vertigo or dizziness can occur as features of migraine, as can motion sickness and leg cramps. They can correlate with a child who has migraine. So I ask all these questions, and usually by the end of just taking this history, I know that this is going to be a primary headache versus a secondary headache. But that doesn't negate the fact that we're going to then need to move on to a physical examination. I actually put the answers to these questions, primary versus secondary, into a little table. So again, length of the illness, if it's chronic and most importantly, if the examination is normal, then we're probably talking about a primary headache. Recurrent or daily headaches usually go along with a primary headache. Headaches getting worse go along with secondary headaches. Location for migraine can be almost anywhere, including posteriorly, but the vast majority of the time it's either frontal or temporal. Increased intracranial pressure oftentimes has posterior emphasis. Throbbing or pressure are the features for migraine, pressure for increased intracranial pressure. In terms of the time of day, I mentioned about the early morning being the worst for increased intracranial pressure. The frequency can vary with days on, days off for migraine, but it's a constant sort of headache building up over time with the secondary headaches. Nausea and vomiting are very common features of migraine. As I had mentioned, interestingly enough, increased intracranial pressure can cause vomiting, but it tends not to cause nausea. So if you get vomiting without nausea, I kind of always pay attention to that. Visual aura occurs with migraine. Diplopia occurs with increased intracranial pressure, and photo and phonophobia with primary headache or migraine. So again, you can see by just going through these historical features and going through a very careful history, you probably know the diagnosis and know where to go. But again, physically, oops, I typed the wrong thing here. Let me do next. Physical examination is extremely important. Physical examination in a patient with migraine is normal. If the physical examination is not normal, then your diagnosis is not migraine. Okay, so unless you're talking about some transient ptosis or something like that, or a complicated migraine such as hemiplegic migraine, but the garden variety migraine without aura has a normal examination. So what are the key features to look at? Well, the most important feature, and the one that unfortunately many of my students and residents in the United States are not very well developed at, is looking in the back of the eye. It is extremely important to look in the back of the eye, to look at the disc, okay? Papilledema is a sign of increased intracranial pressure. And in the slide here, you can see, if you look at that disc margin, it is not flat. It is not crisp. It's fuzzy. It's broad because that disc is elevated. And if you actually, I can't, here, if you actually look at these blood vessels, look at how they come and then they sort of come up and down. They're going over this mound. Again, the blood vessel here comes up and then down. It's going over this elevated disc mound. That is papilledema. That is a sign of a secondary headache. That patient needs neuroimaging soon. Diplopia, obviously, we talked about diplopia being a sign of increasing intracranial pressure. If you have this plus this, again, neuroimaging is important. Looking for a hemiparesis, looking for ataxia, okay, and looking at the reflexes. Very simple features, okay, that can usually be accomplished within 5 minutes. As the slides indicates here, 99% of children who will have an abnormal scan indicating that this is a secondary headache have at least one of these features, and 50% will actually have all of the features. So again, a very focused history with a then very focused physical examination, and then you can say, this is primary, this is secondary. Here's my next step. For secondary, it's neuroimaging. For migraine, it's then going on and deciding what we can offer in terms of treatment options. So the American Academy of Neurology, as you can see, over 20 years ago, stated in a publication, obtaining a scan on a routine basis is not indicated in children with recurrent headaches in a normal examination. They suggested neuroimaging be considered if there's a recent onset. Okay, so the headache's been going on for a month or two and they're getting worse. Change in the quality, it's getting worse. Abnormal physical examination, we just went through that. And interesting enough, they also put in the coexistence of a seizure. And seizures oftentimes can stem from cortical irritation, from tumors, from vascular malformations. So if there's some cortical irritation causing seizures, that may, and the patient also has headache, that may warrant neuroimaging to just exclude the possibility that there's something there. So that was the recommendations actually over 20 years ago. So if we look at primary headache, which is where we're going to focus the rest of this talk on, because that's the majority of the headaches. I specialize in headaches, and every week I must see 30 patients with headaches, okay? Over the 30, 40 years of doing this, with that many patients, I can tell you I can count on one hand the number of tumors that I've found. So the vast majority of children are actually primary headaches, okay? When we look at the spectrum of primary headaches, on the one side, on the left-hand side, migraine with aura, okay? But aura only occurs 20% of the time. The most of the children will have migraine without aura. And then on the other end of the spectrum is tension. And whether tension is a distinct entity completely separate from migraine, or it is part of this primary headache disorder spectrum, is a bit controversial, and it tends to be kind of kicked around. And there are certain schools that say, no, they're two separate things. And there's other schools that say, we get into a blended effect. But the bottom line is the pathophysiology still remains the trigeminal system, as we'll see in a second. We also have to be cognizant of rebound headache and what's called medication overuse headache. So we have to ask people, what do you do when you get a headache? And I have, unfortunately, many adolescents who have very frequent headaches, and they're taking over-the-counter such as ibuprofen, but even Tylenol on a daily, sometimes multiple times a day basis. That's a really bad idea, not only for their GI system and kidneys, but it can actually cause more headaches. So it's medication overuse. And the current recommendation is that you shouldn't be using an over-the-counter medication more than 3 days a week if what we're talking about is headache. Because if you use it more than that, it can actually lead to causing more headaches. And I can tell them it just makes things worse. And I know you want to reach for something, but reach for it when it's bad, not just because, hey, I have a headache and here's something to take. Okay, this is actually an interesting little line actually from a very famous textbook that we use in the US to train our pediatric neurology fellows. It's called Fenischel's Clinical Pediatric Neurology Signs and Symptoms Approach. It's in its 9th edition. The most recent edition was published in 2024. But in his editions, Dr. Fenischel has passed, so his proteges are now publishing it. But he stated in the book, you talk about migraine, it said one of the few remaining neurologic disorders which the physician cannot stumble on the diagnosis by imaging the brain. So the first thing you do when someone walks in saying, I have headache, is not do imaging, which unfortunately oftentimes occurs in the US. But it really begins with taking a history, looking at the family history. That's really important because of the genetic predisposition to migraine, and then the associated features, such as the nausea, the vomiting, the photophobia. So that's how you make the diagnosis, not by imaging the brain. Okay. I just want to look at the actual criteria set forth by the International Classification of Headache Disorders. And this is from 2018. This is in their version 3, but most of the versions say exactly the same thing. And they say the criteria to make the diagnosis of childhood migraine without aura is you have to have recurrent headaches. And they picked the number 5 or more lifetime headaches. And they said the headaches have to last between, 2 and 72 hours. It's important to recognize that migraine in children is shorter than migraine in adult. The average migraine in adult lasts a day to 2 to even, believe it or not, 3 days. But in children, the average length of the headache is usually 2 to 4 hours, okay? Which is why in some of the early studies looking at triptans and looking at the efficacy, which they weren't able to show versus placebo in children, is because their window was too long and kids were getting better from their migraine spontaneously and they couldn't show the triptan effect. But if you looked at a shorter window, then the triptans did indeed help. So important just to recognize, again, kids are a little bit different from the adults. Then any two of the following four, okay? Notice that they say bilateral or unilateral, frontal or temporal. So they recognize that bilateral frontal is not an uncommon feature in a childhood migraine. Throbbing or pulsatile, if you can get that from the child, moderate or severe in intensity. I usually define that if the child is actually coming to the office specifically with the chief complaint of headaches, it's probably at least mild or moderate or severe. Otherwise, why would they take the time off to actually make a trip just specifically for headache? And it's aggravated by physical activity. So I ask, what do you do when you get a headache? And they'll often say, well, I stop and I go lie down, or I, you know, go away and be by myself in a quiet space. They don't continue to play games and run and jump and play because physical activity makes it worse. And then any one of the following two, which is nausea and or vomiting and photo and or phonophobia. Oftentimes, it's very easy to get positives on every one of these features, and it can be very easy, obviously, in that situation to say, yeah, this is indeed childhood migraine. So let's switch from that sort of, diagnostic differential, primary versus secondary, and recognizing some of the clinical features of migraine. And now talk a little bit about the pathophysiology. Many families will say to me, sitting there with the child clearly has migraine. Well, how come? Why, doctor, does he have this? Or why does she have this? And that's where your family history becomes extremely important. And I will always ask, and I don't ask who has migraine in the family. I ask, is there anyone else in the family who has problems with headaches? People do not understand what migraine looks like. Many physicians don't understand, let alone the public. There's a lot of misconception out there. And so I just say, what about headaches? And all of a sudden, out will come, mom will say, oh, well, I used to have them, or my mother had them, or gee, dad has them, or, his brother has them. Okay, so you can say, well, look, there's a family tendency here. This is a genetic disorder. And it kind of takes that fear that all of a sudden these headaches are being caused by a tumor, and it takes away, oh, yeah, that's right, grandma had them, and mom's got them, and now, sister's got them. And what it is, it's a genetic disorder to a brain sensitivity, okay, in the brain stem, in the trigeminal, excuse me, in the trigeminal system, which then can be easily triggered. It's a sensitivity. It's like, I think about it as a rheostat, setting the temperature. When does it kick in? When does it kick off? And some people have their set at higher levels and at lower levels. And patients with migraine, their pain sensitivity is set at a lower level, if you will, in the brainstem. And then that triggers the headache pain. Now, let's see, do it this way. Triggers. What can bring these on? What can trigger? Well, there's a number of things, and we, I think, recognize most of the things on this list. The big one for children is school, because school causes many children stress and anxiety. And we know, at least in the United States, that the incidence of headaches in children is much higher during the school year than off times, such as vacations, summer, holiday, that sort of thing. So there clearly is a stress which then triggers this pain sensitivity. Sleep deprivation, are they getting enough sleep? Okay. What about eye strain? Okay, everyone, it's very common for kids to be brought to the eye doctor to have their vision checked. Oh, they need glasses. Well, yeah, if you're sitting there all day and you're squinting at the board and you're tightening your muscles, that can then bring on or trigger a migraine. Okay. I put a bottle of Coca-Cola and caffeine, the coffee, on the list because we have to be careful. It's another question that I always ask children. How much caffeine do you consume? Oh, I don't drink coffee. Well, I get that, but how many, sodas do you drink? And, let's forbid that you do, like some of these fortified sodas, Red Bull and those sorts of things. What about food and knowing which foods can trigger? We actually have our dietitian put together a list of foods that can be problematic for people with migraine, and I give it to the families. And oftentimes, and I say, this is a food list not just for your child, but it's also for you. I mean, mom gets headaches. I say, take a look at this. You may find it interesting. Okay. So these are sort of things that we go through and ask about because they're common things that can make the headache worse. But once we get back to that, let's do a little bit of diving into headache pain and what is the pathophysiology of headache pain. Because by understanding that, then that gives us a door to enter in. Well, what are our therapeutic options that we can offer the child and the family? Okay, so migraine pathophysiology. This is a neurologic disorder. When I was training, that was not 100% clear. We always thought of it as a vascular disorder, but this is a disease of the brain involving the hypothalamus and the trigeminal system. There are vasoactive neuropeptides, an important one being CGRP, and we'll talk about that more. And these neuropeptides are released from the trigeminal C fibers and activate the trigeminal A fibers, leading to an afferent stimulation of the trigeminal system. And I'll show you a diagram of that in a second. But this is a reflex loop, okay, that gets activated. And by activating the trigeminal system, then from there it spreads upward where you then start to recognize pain. The neuropeptide receptors involved in the migraine pathway include CGRP, but also some other ones that result in activation of cyclic AMP. And one of the important things to recognize, there's two important chemical to recognize when we talk about pathophysiology of migraine. One is serotonin, and that one's been around for a long time, as we all know, because we use things like sumatriptan to treat migraine. And the other one is CGRP, okay? Serotonin's role is to stabilize the trigeminal reflex pathway, okay? So it helps stabilize, whereas CGRP actually is the neuroinflammatory pain messenger. Okay, so they're kind of on opposite sides of the coin. So serotonin's a good guy trying to help stabilize things, and CGRP is kind of the bad guy mediating pain. So this is the diagram here that I'm talking about. Okay, so we have in the periphery, we have our dura with our blood vessels, and we have the innervation of the blood vessels from the trigeminal system, and these are the C fibers, and then we have the A fibers going back into the trigeminal system. Okay, so the important components in the migraine pathway are the blood vessels because they contract and they dilate. We have the innervation, and then we have the reflex connections within the trigeminal system, okay? And when the blood vessels in migraine dilate, that's when the neuropeptides such as CGRP leak out and then cause the pain perception. So, mechanism of action for serotonin is to cause some vasoconstriction, stabilizing the blood vessel, cutting down on the leakage of neuropeptides. It inhibits transmission, okay, not only in the centrally, but also peripherally. So it's an important stabilizing neurotransmitter that has been around now for several decades in terms of its therapeutic role with migraine. In 1982, a neuropeptide, a rather small neuropeptide, only 37 amino acids, was found, and it was also found to be expressed in the trigeminal system. And interestingly enough, they found that it increased during migraine headache, and when you gave a triptan, you actually inhibited its release. And so CGRP now is on the main stage for the treatment of migraine. So both serotonin and CGRP are huge therapeutic targets, trying to decrease CGRP and trying to increase serotonin to stabilize this reflex loop that is the central processor for migraine. Okay, so with that kind of understanding of where the current thinking is in terms of pathophysiology and pathways, and obviously not all of the neuropeptide mediators or other ones as well, but the two current important ones being serotonin and CGRP. What do we do to treat kids? Okay, child comes in, doctor, I have a headache, and you know all this wonderful stuff about brain pathways and serotonin and CGRP, but what are you going to do with it? Well, the first thing you need to do, and we talked about this a little bit earlier, is try to figure out what is the headache burden, okay? And by headache burden, I talk about not only the frequency, I have them every day, I have them once a month, but how bad are they? Well, I have them every day, and on a pain scale of 0 to 10, they're a 2. Well, okay, that's not so bad. Or you could have the patient who says, well, I have 2 headaches a month, but when I get them, they're 8s. Okay, so, one really takes the person down and the other doesn't. So you have to kind of weigh in benefit. What are the impact of their headache frequency and their burden, and then customize the treatment for that individual patient and their own burden. If the burden is relatively mild, I get 1 headache a month, it's probably on a pain scale somewhere between a 5 and a 7. Well, then offering an analgesic may be the way to go, something to abort it, maybe even considering using sumatriptan if you want to go that route. Or if you're talking about, no, I'm having headaches several times a week, they may need something to help them get through the day, but more importantly, they need to have something so they don't get so many headaches. I oftentimes try to explain it to families by saying, it's like high blood pressure. You want to take a medicine so that you don't have high blood pressure. You may need to take a medicine so that you don't have frequent headaches. Okay, so how do we do this? Well, the first thing that I like to approach is in a multi-pronged approach, not just, okay, let's go to the medicine shelf and see what we can pull off today, but really let's talk about what are your lifestyles. And we're going to go through some of the important lifestyle features for children and adults as well. Then we often do what we call tier 2. I am a big fan of vitamin and mineral supplementation. And the 2 that have the most weight are riboflavin, vitamin B2, and magnesium. So I will oftentimes talk to them about, well, I know you don't want to take a prescription medication every day, but would you be open to supplementing some vitamin B2 and some magnesium on a daily basis? And you can actually, I've had amazing success with that. There are some proprietary forms of this offered by Amazon, where they can buy it riboflavin and magnesium in one pill, or they can just go out and get some magnesium and riboflavin and just take the two separately. Oftentimes they're buying that from Amazon as well, since Amazon sells everything in the United States, but that's another issue. Then there are complementary and alternative. What about relaxation? What about cognitive behavioral therapy? There's a role for some of these things, and it feeds back into lifestyle. And then, depending upon what sort of improvements we see with that kind of tier one, tier two approach, then we talk about medications. What can we take acutely? What can we take long term? And if all of this fails, then there are little more aggressive modalities, such as nerve blocks, Botox. There are some medical stimulation devices similar to TEMS units for the back. But most of the time, we don't need to go there, and many of these are not covered by insurance companies in the United States. So, what are the lifestyle issues? Sleep, good sleep hygiene. Unfortunately, many of my adolescents, they go to bed late because a lot of times they're on their cell phones, YouTubing, TikToking, Snapchatting, whatever they're up to until, midnight or 1. And then, of course, they have to go to school, and school begins at 7 a.m. So they're up at 4, or they're up at 5 or 6, running out the door. Of course, running out the door without breakfast, without drinking. Or maybe they grab a cup of coffee, which is even worse. So we look at what are their lifestyles, and is it appropriate for their age? Avoiding caffeine, okay. Well-balanced meals, okay. Again, avoiding caffeine and well-balanced meals is almost not compatible with being an adolescent, okay, at least in the United States. It's a real problem. And that superimposed with sleep hygiene, that superimposed with poor hydration, and that superimposed with excessive screen time really makes a huge battle right here. We haven't even begun to talk about medical therapies. We're talking about what can we do lifestyle wise. And the other thing is, unfortunately, we have a society today which is pretty sedentary, and it's really important to have the kids get up and do something. Go ride a bike, go walk, do something, if not every day, at least several times a week. And dealing with stress, again, we mentioned that school is a major stress, and just recognizing that and helping the child deal with that. In the world of vitamin supplementation, like I mentioned, the ones that there are a number of them in literature that have been shown helpful. They're listed here. But the two that I'm a big fan of are riboflavin and magnesium. The dose for vitamin B2 riboflavin for an adult or an older teenager is 400 milligrams a day. The dose of magnesium is 400 milligrams per day. Okay, you can go up to 600 on the magnesium if it's a big person. For a younger person, sort of pre-adolescent or older child, 200 milligrams of riboflavin or 200 milligrams of magnesium. And again, these are taken on a daily basis. There's really no significant side effect profiles. Sometimes the magnesium may have a little bit of a laxative effect, but I found that very rare. And so well tolerated. And families usually like to start there. Now, when we talk about pharmacologic measures, okay, so we talked about lifestyles, we talked about some supplementation. What about pharmacologic measures? Well, there's two major categories, right? There is the acute treatment. Doctor, I have a headache right now. What can I take to make it feel better? And then there's the prophylaxis, the preventative treatment. Doctor, I get a lot of headaches. What can I do so I don't have so many? If we look at the acute treatment, the first thing that most people tend to reach for are over-the-counter medications. And this is a publication from a while ago by a friend of mine who unfortunately has passed away, Dr. Lewis, that shows that ibuprofen and acetaminophen are both first lines. In their study, they felt that ibuprofen was a bit better than acetaminophen, but both are equally good to start with, and they're also readily available. You don't need a prescription for these. So and oftentimes the families already have these in their home or have access to them. And then the other treatment after the over-the-counter medications would be the triptans. So in the world of the triptans, which I've sort of labeled here abortives, there are actually quite a number of them. There's sumatriptan, which we're all familiar with since that was one of the first ones to actually be used clinically in the early 90s. Then there's rizatriptan, zomatriptan. I split them into three groups. The top group, they have relatively short half-lives, so they're good for relatively short headaches, okay? The middle group has a slightly longer half-life, so it's better for headaches which have an intermediate, usually more adult-type headaches, which last longer. And the last group has very long half-lives. In fact, frovatriptan has a 21-hour half-life versus sumatriptan, which is a 2-hour half-life. In pediatrics, most of the time we're using sumatriptan or rizatriptan or zomatriptan. In the United States, the rizatriptan, the zomatriptan come as melt tabs. Okay, so they don't have to swallow a pill. You just put this little tab in their mouth and it melts. And some of them also come as nasal spray. So it gives you options for children who can't swallow pills very well. Okay, so what are the facts about the... I'm not exactly sure. So the facts about the serotonin agonists is they actually work on both the blood vessel, constricting it, and the nerve fiber, okay? They tend not to be used, because of their vasoconstrictive effect, they tend not to be used in more complicated migraines, such as hemiplegic migraine. One of the things that came out early on is that there was a concern that because these were serotonin agonists, is that it would increase the risk of serotonin syndrome if they were being used with SSRIs or SNRIs. And that actually has been shown not to be true. So early on, we tended to not give triptans to people who are on SSRIs or SNRIs, but now there doesn't appear to really be an issue with that. What are the side effects of the triptans? Well, they're listed there. The most common one is maybe a warm or hot sensation that you can feel in the face. Rarely tightness in the chest or the throat. Most children tolerate these very well, and they're relatively short-lived, as you'll see, less than 30 minutes. We tend not to give triptans to folks who have uncontrolled hypertension, pregnancy, complicated migraines such as hemiplegic or basilar, and a history of heart disease, especially vascular heart disease, tend to ward away from that. The good news is in pediatrics, most of the time, those aren't issues. Those are much more common issues in the adult population. Okay, so now we're back to our headache burden. What about if the headache burden is significant? What do we want to do? Well, in the world of preventative medications, this is a list, and you're probably familiar with many of the medications on this list. Classically, beta blockers such as propranolol have been used. Cyproheptadine is very commonly used in pediatrics, young children. Amitriptyline or nortriptyline, the tricyclics, again, not uncommon in pediatrics. And also the anti-epileptic medications. Topiramate actually is my favorite. I think it does quite well. Does have some side effect profile. Valproic acid is also very popular and common, but we tend not to use it in pediatrics. It's used more in adults, especially in adolescent girls, where it can have some issues with predisposition to polycystic ovary disease, weight gain, and other sorts of things that young ladies, it's also teratogenic, as you know, so lots of reasons why this drug tends not to be used frequently. Calcium channel blockers, you have available to you flunarizine. We do not have flunarizine available in the United States, but that has been shown to be effective for pediatric headache. We have tended to use something like nibodipine, which is not as good, and I tend not to use calcium channel blockers unless I'm talking about hemiplegic migraine, which oftentimes is due to a calcium channel defect. Okay, what about CGRP? Well, I already mentioned that this is a very important neurotransmitter because it transmits pain, okay? It's located in essential regions for migraine pain. The plasma level goes up when a patient has a migraine attack. The plasma level falls after triptines. If you infuse, and this has all been done in the labs, if you infuse CGRP into a patient, it will trigger the migraine pain. So there are obviously now medications that have come out to target CGRP. And the first ones that ever came out were monoclonal antibodies, which either targeted the CGRP or the CGRP receptor. And now we have a
Professor Koch, tell me, have we lost him?
Yes, he has dropped
Okay,
that
all
reaching.
right. I'm sure he'll get back. I'm sure it's just a fluctuation there. So Shalmit, in the meantime, I hope I've just sent him a message. I hope he'll be able to join back. So somebody was asking about diclofenac in the older kids, and yes, it has been used. It has been effective. It's just that, as Prof. Koch had mentioned, one would not want to use this on a daily basis or more frequently than anything more than a week, once a week. And of course, it has to be appropriately dosed. We have used it, and it has been effective for a few of the children who have had infrequent headaches that last a really short time. and are not severe. So in scores of 5 to 8, generally they have responded well to the use of diclofenac. And please remember the dosing is approximately 0.5 to 1 milligram per kg per day. So Irene has appreciated the oh, good Lord. Yeah, Irene has appreciated the
Hello.
call. Hello, Prof. Cook, is that
Hello.
you? Yes, we're still here. Just reshare and continue. All we did was discuss the diclofenac dosing. And then I was just dealing with the questions while you were away. There was something about referred pain, and that's quite obvious. And somebody else wants a link for the CPD. We will share that shortly. Yeah. So I think we just proceed. I think we just have a few slides left.
Connection. We had a little storm pass through I'm up here in Runda, and we had a little storm and it lost my internet connection. So I'm trying to connect back on, but I'm actually right now using my phone. So this is probably an appropriate time to just, like you said, just entertain.
Questions. Yeah.
Yeah,
Yeah.
exactly.
Great. Yeah. Shalmith, feel free to share the CPD link for those who must go in the next 5 minutes. And one of our residents was just asking about the linkage between the neuropeptides and the riboflavin. How do you feel, Professor, that these are connected?
Yeah, that's a very interesting question. And there's lots of theories about it. There's no hard science to prove it. But the feeling is that the riboflavin, at least the riboflavin is probably acting on the basis of mitochondrial stabilization. There's a lot of activation of cyclic AMP with the pathophysiology of migraine. And so stabilizing the mitochondrial machinery is kind of the feeling behind the riboflavin. In terms of magnesium, it's a little bit easier to postulate the role. Magnesium is a divalent cation and similar to calcium, and it actually can serve as a calcium blocker. So just like we would use, flunarizine or another calcium channel blockers, you can also use magnesium as a calcium channel blocker. So that one's a little bit easier to sort of postulate.
Great. And there have been some concerns about the use of triptans in children who cannot be able to articulate, especially so the side effects, vasoconstriction and all that, vasospasm. So somebody is asking, how long can you use triptans for?
So the triptans are used for short-term use. Just, you have, I think, let me.
I think you're double joined now. Your previous link and your current link. 1 minute to go.
Let me try to turn off.
Wonderful. Yes. So in the meantime, no, we can't hear you, Prof. Okay, maybe what we could say about the triptans is we have used them as abortifacients, to stop the, right? We cannot hear you again. Hey, Prof, you're muted. We cannot hear you, Prof. We cannot hear you. I think you're muted on your iPhone.
Yes, you're absolutely correct. You should be able to hear. So what I was trying to say was that triptans should not be used more than 2 days in a week. Overuse of triptans will clearly lead to medication overuse headaches or rebound. So the interesting thing is in the United States, if I write a prescription for a triptan, say sumatriptan, the maximum number that I can give the patient for 1 month is only 9 pills. So, and I just tell them, you're not supposed to use this more than 2 times a week. You get 9 pills, you have to divvy that up over 30 days. And so, if you do the math, that's, 2 per week, maybe with 1 extra. So you have to be careful with the triptans. They work very, very well, but they also can cause medication overuse headache quicker than overusing over-the-counter medications.
Great. Yes, and I think it actually goes for all the other interventions that we use, that there has to be controlled use. Overuse also leads to other problems. So I
Absolutely.
think Nora Obungu, who is one of our instructors, also wants to understand what type of magnesium is recommended for pediatric migraine. I'm not
Uh,
100% sure if that's clear. I don't know if
uh,
the dosing she's interested in, or the brands, or the type of magnesium, because clearly I don't believe we're looking at intravenous.
Yeah, exactly. So actually, that's not an uncommon question that I get from parents. What type of magnesium? Um, many type, many magnesium. I usually get a magnesium which contains several salts. The ones that have been shown to be the safest and easiest to use are magnesium oxide, magnesium glycinate, and magnesium citrate. Okay, so those are very common, and oftentimes magnesium compositions will include a little bit of all 3 of them. So I always have the family look at the label to see what exactly is in it. But for the most part, any magnesium salt or any mixture of the magnesium salts is adequate.
Great. That's great. That's a good clarification. And I think there is one more question before we close, and that is about your recommendation regarding caffeine-based molecules. I know we have Better Pine and we have some other local formats like Panadol Extra. I'm not 100% sure, and I think there's some other formats that include pain stop and they include caffeine. What do you feel
Yes.
about the use of caffeine for headache? Because again,
Yes.
it can cause headache.
Yes.
Yep.
This is a very good question because uh, we have a similar over-the-counter medication. It's called Excedrin migraine, and the families will often buy it because it has migraine on it. And I just ask them, "What is in it? Have you looked?" And they say, "Yeah, caffeine." And I said, okay, now we just talked about the pros and the cons of caffeine. So caffeine is not dissimilar from sumatriptan. In the short pulse, caffeine can actually help. In fact, many, many, many years ago, it was not uncommon for us in the United States if a patient had a migraine headache to say, go have a can of Coca-Cola, okay, specifically to get the caffeine. But again, doing that too often is a bad idea. Just like doing sumatriptan too often is a bad idea. Acutely, it can help. And I don't have a problem with Excedrin migraine if they're using it sparingly. My problem is oftentimes when they use these compounded headache preparations with caffeine, there is a real slippery slope in terms of overusing it. So I tend to not encourage the use of caffeine.
Okay, so I'm not 100% sure you're able to answer the questions about where in Kenya people should get the riboflavin and magnesium supplementations. And disclaimer, I think there's several health shops available that would have standard preparations. And I think most hospitals as well, they have a place where you can buy those kind of supplements which do not require prescriptions. That would be my advice regarding that. So finally, as
That's
we close, Prof, CGRP inhibitors, this is the new kid on the block. And the last time we calculated the cost of obtaining that in our backyard, it seemed astronomically out of reach. What do you feel about ongoing availability? Because as people have continued to use it, they have seen benefit for adolescents and small groups of children. Any comments about that? I think there are recent studies as published as recently as August 24. And I don't know, what do you have to comment about that?
and we're specifically talking about which compound now?
Any of the CGRP inhibitors?
Yeah. Yes.
Yeah.
Yes.
Yeah.
Yeah, I think that the CGRP inhibitors have revolutionized the treatment of migraine, specifically in the adult population. Unbelievable positive effects. The parents come in, it's been transformative. Our problem is in the United States is that they're not FDA approved for anyone under 18, which doesn't mean that they can't be given. It just means that the family has to pay for it. And as you mentioned, they cost roughly 1,000 to 2,000 US dollars per month, which is obviously out of the reach of the vast majority of families. But when I've been able to get a hold of them, and I have been able to get a hold of them, our pharmacy has been very creative in trying to get these medications, especially for the older adolescents 16, 17 years of age. They've been very helpful. I think they're very promising, and we just need more pediatric studies to show that the effect of these medications for children is going to be just like the effect of the triptans was for children. So I think, the adult effect is going to be shown in pediatrics. We just need the studies to get us there. But right now, our hands are tied because of outrageous costs.
Great. So I think then that brings us to the end of this presentation. We would only like to say thank you so much for taking your time to bring us up to speed with this problem. Yes, every clinic that we hold, we do not lack at least 5 children out of about 20 that have headache for one reason or the other. We do have studies from our own population that have used sodium valproate very safely and been able to remain headache-free after reducing the use of that. I understand there are limitations, but then safe anti-seizure medications like zonisamide that have been explored in other settings in the recent past haven't been easily available to us. So we have used what has been available to us, and it has been effective. Of course, well used in low doses. It has been a very good way of preventing medications for at least 6 months for the vast majority of patients. So thank you so much, Professor Koch. I think we shall end the meeting there. Thank you so much, CME office.
Thank you. I really appreciate it. And sorry for my technical difficulties secondary to the weather.
Not a worry. So thank you and bye-bye, everybody. Enjoy the rest of the day. All right, bye.